This conference will now be recorded.
Hello everyone, I am Dr. Juma Bishwas. I am the mentor of MRCUG Health. Today I will going to present a very recent talk that is Androgen in Postmenopausal Women that is published in October 2022. Before starting of the presentation, I will request you to subscribe our channel and press the bell button so that you can get updated about recent videos. So let's start. So as we know that androgen therapy for improvement of the sexual well-being and libido and the sexual arousal in the postmenopausal woman, it will exerted by the effect on the central nervous system. And testosterone is the most prevalent active sex steroid in women, and it exerts its action via the androgen receptor. And it's also an obligatory precursor for estrogen biosynthesis. Testosterone circulates in the woman at around 5% of the level found in the man. Woman produces around 3 to 4 times more testosterone daily than estrogen and is approximately 100 to 400 microgram. So you can see that the level is more in woman, the testosterone, that is 5% of the level found in the man. And you can see that if you compare with the estrogen and the testosterone level, testosterone is more in like 3 to 4 times than an estrogen level in our circulation. And this is the biosynthesis of all androgen hormone. You can see dihydroepiandrosterone sulfate is completely synthesized from the adrenal gland. And from there, 30% it converted into dihydroepiandrosterone and remaining 20% from ovary and half of that like 50% from adrenal gland. Dihydroepiandrosterone ultimately converted into androstenedione, and it also converted or synthesized from ovary and adrenal gland. Androstenedione 50% is converted into testosterone, and remaining 50%, half of testosterone come from ovary and adrenal gland. And this testosterone in a peripheral tissue converted into estradiol, and few of them converted into dihydrotestosterone under influence of 5-alpha reductase for producing their biological effects. And most of the testosterones bound with the sex hormone binding globulin, and only 1 to 2% of the testosterones are remaining free, and that is we call free androgen level. So certain factors, certain hormone influences sex hormone binding globulin level, and that's also affect on the free androgen level. So you can see oral estrogen, tamoxifen, and oral thyroxine that increases sex hormone binding globulin. And the woman who receiving oral testosterone or having glucocorticoid therapy, or the woman with a high fructose diet, increased visceral adiposity or insulin resistant, they have a very low sex hormone binding globulin, and they have a very high free testosterone level. And this testosterone, if you see, their receptors present almost all the tissues throughout the body in women, includes brain, skin, adipose tissue, bone, and vessels. Regarding effect of aging on the testosterone level, so in our body, testosterone first noted in the girl at the age of 6 to 8 years of age, when there is a maturation of adrenal zona reticulosa, and they produce dihydroepiandrosterone and androstenedione sulfate that signal the onset of adenarche. And in our body, testosterone reached to the peak level at the age of 18 to 24 years of age. And between 20 to 40 years of age, there is a gradual decline of the testosterone, like 50% decline in total and calculated free testosterone, dihydroepiandrosterone sulfate, and androstenedione. And due to age-related atrophy of the adrenal cortex, we can see that circulating androgen level dropped to 10% by the time of menopause is reached. 50% from them originated from the ovary, and 40% among them is converted from peripheral conversion. Okay, so you can see that the total androgen level dropped to only 10% at the time of menopause. So when we think about starting off treatment, the guideline mentioned that you have to measure the total testosterone level before starting off any kind of treatment, just to make sure that the level is not in the upper range before treatment. And as there's no correlation between the free testosterone level and the biological activity of the testosterone, so assessment of the free testosterone level is not recommended. And guideline recommended that if you want to see the effectiveness of the testosterone treatment, that can be determined the symptom improvement. And for the assessment of the total testosterone level within 2 to 3 months, you have to do it to ensure that the level remains within female physiological range. Because if it is more than that, that can promote any kind of adverse effects. In women, the testosterone plays a very important role for maintaining of female sexual function, especially in stimulating the libido and sexual interest, as well as maintaining desire. Testosterone also contributes to libido and sexual arousal and orgasm by acting on the central nervous system to increase dopamine level. Testosterone also involved in maintaining of normal metabolic function, muscle and bone strength, urological health, mood, and cognitive function. So there's one definition you need to know that is called female sexual dysfunction. It is characterized by that is a long-standing problem, that is a chronic problem in a domain of desire, arousal, orgasm, and pain. And it is quite high in a woman between 40 to 64 years of age. The prevalence is about 32.2%. For diagnosis of female sexual dysfunction, the symptom should be results in clinically significant distress, and that should be persisted for minimum of 6 months. So if we start a treatment of testosterone, so regarding the systemic benefits is very unlikely. Like there's some evidence, there's very limited evidence supports that can improve the other systemic manifestations like cognitive performance or in a delay cognitive decline in a postmenopausal woman, as well as there's also a lack of data that can shows that a physiological dose can improve the bone mineral density, lean body mass, or muscle strength. There are two types of formulations nowadays we can get. One is oral formulation and one is transdermal route. Oral formulation nowadays, it is not used because of poor absorption, because of undergoing a fast metabolism, and it has also exert adverse effect on the HDL cholesterol and liver function. Regarding transdermal route nowadays, that is preferable route of administration. And there is a various transdermal androgen therapy in the treatment of women with sexual desire. And you can see that all of the transdermal preparations can improve the sexual desire and also increase the satisfying sexual activity. So there's a question that shall we start testosterone to women who have low sexual desire? According to the NICE recommendation, the answer is no. You can only start the testosterone supplementation for the menopausal woman with low sexual desire if estrogen therapy alone is not effective. That means you have to start with the HRT, and if it is not effective, only you can start the testosterone along with the HRT. There are various testosterone products are available for the treatment of male hypogonadism, including intramuscular, subcutaneous, implant, transdermal patches, and gels. But off-label, we can use testosterone gel and cream for the woman. But currently, there's no preparation specifically designed for use in the woman in UK. And if you want to use a testosterone, the testosterone level in the woman are approximately 5% of the male level. That means a very low level. You have to start with that. That is the physiological level. Otherwise, it will exert adverse effects. And there are various testosterone preparation currently available within the UK. That is Testogel, Testim, Tostran, and Androfem. Regarding monitoring and the surveillance, if you use a testosterone gel or cream, you have to advise the woman to use it on clean, dry skin on the lower abdomen or upper thigh. Response of the therapy usually require at least 2 weeks to manifest. So treatment should be trialed for a minimum of 3 months. If there is no improvement after 6 months, then testosterone should be discontinued. There are so many androgenic adverse effects we know. The good thing is that if we give a physiological dose of the testosterone, the side effects are very minimal, like acne, hirsutism, these things. But if we use more than that, then there will be other adverse effects. Along with the hirsutism, acne, alopecia, there will be other features of virilism. Testosterone does not increase the risk of breast cancer. Also, it will not increase endometrial cancer. And there's no evidence that it can increase coronary artery disease, stroke, and thrombosis. And currently, if we use a transdermal testosterone therapy, it doesn't have any adverse effect on the lipid profile. There's no effect on rise of blood pressure, blood glucose, or hemoglobin A1C. So these are the strong evidence of regarding the treatment protocol. So for the diagnosis of hypoactive sexual desire dysfunction, it should be a clinical practice and they need a thorough clinical assessment. Treatment for hypoactive sexual desire disorder should follow a biophysiological model. Testosterone therapy exert a beneficial effect on the sexual function by increasing the number of satisfied sexual events per month, increase sexual desire, arousal, orgasmic function and responsiveness, reduction in sexual concern, including sexual distress. If you use a systemic testosterone therapy in a physiological dose, that is the premenopausal woman, there is an increase in acne and hair growth, but there is no other androgenic effect. That means you also always need to give a physiological dose of testosterone to get the minimum adverse effect. Oral testosterone therapy associated with adverse lipid profile. So nowadays, preferable route of administration is intravenous. These are the limited evidence that baseline total testosterone concentration should be measured before starting of treatment, and that should be repeated 6 weeks after commencement. Sign of androgen excess can be screened for every 6 monthly. And if you see that there is no benefit after 6 months, then you have to stop the treatment of testosterone. Testosterone may improve well-being, but data are inconclusive. Available data to date show that short-term transdermal testosterone therapy does not appear to impact breast cancer risk, but randomized control trial data for long-term breast cancer risk is insufficient. So short-term preparation, there's no risk, but in the long-term preparation for breast cancer, there's a very limited data available over there. There's weak or no evidence that association between endogenous androgen concentration, sexual function in the woman is uncertain. There is no cutoff level that can be used to differentiate women with or without sexual dysfunction. There is an insufficient evidence that testosterone enhances cognitive function or improves depressed mood. There is an insufficient evidence that testosterone improves musculoskeletal outcome, including BMD, that is bone mineral density. There's also a non-significant trend to increase DVT that has been seen in the transdermal preparation. However, it is actually associated with estrogen therapy, and safety data for the testosterone therapy more than 24 months is not available. So this is all about this talk. If you have any query, you can ask me on comment box. I will be happy to answer all of your query. And lastly, I will request you to subscribe our channel and press the bell button so that